So I thought it was important for Larry and I to give our experience because we have had, over a year for us and several years for him in doing the lung cancer screening program. And we really, on my part, thought it was going to be much easier to implement than it has been. So I'm going to give our experience as well. So you heard that lung cancer screening reduces mortality. It's going to be covered by insurance. Our patients are now asking us for lung cancer screening. And so you've assembled your team of radiologists. You're ready to start scanning. And then you get something that squashes you. So as Larry said, you really need to get input from the rest of your organization. Unfortunately, even though we thought we had all our pieces in place, we had all of the materials available for our referring providers, then we found that there was this committee and this person didn't understand and they're not available for another 6 weeks. And so there was roadblock after roadblock after roadblock. So this is what we're going to talk about, a little bit similar to what Larry had. So before you really start to think about your program, it's best to engage your stakeholders, particularly your primary care providers. You're going to need to assess who's going to be your project manager and where this program is going to reside. There are programs where it's very radiology centered and they sort of run the whole show. In other organizations, you may have a pulmonary clinic that's the main repository for patients who are going to have these positive scans or thoracic surgery. So you kind of need to figure out in your institution where that's best going to reside. And then it's important that you look at whatever EMR interface you have. We have Epic, and so there are some glitches. So for example, in Epic, if you change how many packs per year you smoke and use their calculator, it completely negates everything. So if you went from 3 packs a day to 1 pack a day, it's just going to assume that you're 1 pack a day. So you have to be aware of those kinds of issues and educate your physicians in case they're not aware of that. We have provided the information to our referring providers on the radiation risk. We've given them the language, what we call dot phrases, that they can import into their report that says that they've counseled them about smoking cessation. We've given them resources that they can use, and we've also given them the language to document that shared decision-making occurred. It's a little interesting to me because when we went out to our primary care physicians and met with them, at the various clinics, it did not seem like they were very interested in doing shared decision-making, and what they wanted was for all this to magically happen without any input from them. But unfortunately, the way it's set up through CMS and likely the other insurance carriers, you do require that, and so you need to make it as easy as possible for them, but you need to get their buy-in from the beginning. So there are a variety of ways to do that. For us, we took the dog and pony show out to the clinics and gave information to the clinic managers who could then relay it to their physicians and be a point person. And even though we did all that, we still get complaints, not every day, not every week, but often enough about, I had no idea, why are you making me do this? Why are you making me do that? And we're not, and this was all set up ahead of time, but the communication can never be overly done in our experience. So for the referring providers, they need to talk to the patient about the potential harms and the benefits of the screening. The harms being the radiation risk, the possibility of additional testing, the fact that they may get overdiagnosis, so they're diagnosed with an indolent cancer that probably wouldn't have hurt them, but is now requiring treatment, and what the false positive rate is. And they also need to do smoking cessation counseling. So here's an example of a type of smoking cessation counseling that you could do. If your nicotine patch doesn't work, put it over your mouth. But we have provided them with other resources, which are probably a little bit more beneficial. These are available to everyone. You're probably all familiar with radiologyinfo.org. That's through the ACR and the RSNA, and that has information for patients and for providers about a variety of topics, including lung cancer screening. The quit line here is out of the UW Center for Tobacco Research and Intervention, or what we call CITRI. And this is run by Mike Fiore at UW, but there are resources that are available for everyone in the state of Wisconsin I encourage you to go to that website because there is a lot of information there. Surprisingly, there were physicians excuse me, in our organization who didn't know that this even existed. So again, you cannot over-communicate with your referring providers. Initially, the orders had to be entered by a physician. Now that's been expanded to allow NPs, clinical nurse specialists, and PAs. As Larry had mentioned, you need to have the decision support in your EMR so that these cannot be ordered without all of the elements. And then if you have a self-pay patient, then you need to have a process in place because not all people have insurance coverage and not all insurance covers it. And I'll just say, I think this may be on another slide, but even though with the B grade from the USPSTF, if your insurance policy has not been updated since that took effect, the insurance carrier is not required to cover it until that insurance policy is updated. So there may be some people who fall through the cracks. And so now I'm going to turn it over to Kari to talk to you about parts that she was actively involved in.
Thank you. One of the easiest ways we felt we could get patient education and physician education to get the information that we needed in doing this process was to create these cascading questions. Of course, we brought in our IS team to help us implement this in Epic. It's been a lot of controversy because, of course, we need to get approval from our referring physicians in order to utilize these questions in their order set. So this documented piece of questions was debated for about, I want to say about 6 months. And it actually came down to, these were what we proposed, and we brought it down to about 5 key questions in order to make it easier for the primary care physicians in order to get this ordered. So originally we wanted to make sure that we went off of CMS guidelines and picked up every component that we could so that when a nurse reviewed this to get the patient scheduled, all of those answers that CMS had put forward for us were answered, and we wouldn't have to worry about complying with shared decision making and making sure that the patient had a PAC year of 30 or more, if they were a current or former smoker, and if they were a former smoker and it had been 15 years, they no longer qualified. Make sure they're within age range. That's the first key piece that physicians keep trying to get their younger patients in. So it's nice to know that there's going to be options for that too, hopefully in the future. Making sure they're asymptomatic. This was a huge piece of education on our nurses' side that, you know, there was boundaries. What was actually asymptomatic and what wasn't. So even though it seems pretty simple and straightforward, there were judgment calls that needed to be made. So the physician and nurses really had to work together to get those done. An easy one was the patient did not have a chest x-ray or chest CT in the past year, no history of lung cancer. If they did have a history of lung cancer, that they were disease-free for 5 years. And the big key piece, our nurses at the university take a look at each and every patient before we get them scheduled. One of the things that they're looking for is this documentation piece of the physician offered smoking cessation. The patient was engaged in shared decision making. The patient knew the radiation risks. One of the key pieces was educating the primary care physicians on radiation risks and where could they go to get that information. And if they did have questions, who could they contact to talk to? So these were all challenges as we went through. At our institution, it was very important, I felt, to educate the CT technologists to know what the upfront process was and to know that they could confidently perform lung cancer screening in the way that we wanted with the radiation dose reduced. So again, I won't go into the parameters in which Dr. Goodman talked about, but it is important to have a low-dose scan, and I felt this cartoon was pretty funny, having the bag of ashes on the table. I often wanted to do this to some techs, so this would be very fun to do. With the CT exam, of course, we want to keep it, the CT dose index 3 milligram or lower for an average patient of 5'7", 155 pounds. This being Wisconsin, those are far and few between. But in looking at our statistics that we got back from the registry, we are actually keeping 3 milligray on the majority of our patients. It's just the very large patients that we're having, and it's right within range. So we, I think, are doing a very good job keeping that index in mind. Again, for protocols, you can go to this website with the med physicists, and they provide free lung cancer screening protocols if you're in need. It's a pretty good website. And I'll hand it back over to Dr. Broderick.
So I think Larry went over what the requirements are for the physicians who are interpreting the exams. We have two sort of separate programs. The University of Wisconsin in Madison is set up with the academic institution or academic group division that practices out of the university hospital, and now I'm currently in the community division, and we practice in a freestanding outpatient imaging center, and then we also staff a variety of community hospitals, some of them in Dane County and some of them out. One thing to keep in mind with who you're going to involve in the lung cancer screening is if you are not involved, if you're not a DICO center, and that's a diagnostic imaging center of excellence, which we have at our freestanding clinic, then the registry there's no charge, but otherwise the charge is per physician who's interpreting the CT scan. So that's something to keep in mind. So when you're reading these exams, I mean, obviously it's a chest CT, and we all know how to read chest CTs. We routinely run the MIPS because you can detect nodules more easily on the maximum intensity projection images. It's preferable to run those on a soft tissue algorithm because there is less noise. CAD is encouraged through the regulations, but it's not mandatory. There are a lot of new CAD programs that are coming out, and we're looking at those. We looked at them at STR, and hopefully we'll be getting one of those to use on all of our chest CTs. You have to be descriptive of the nodules, whether they're solid, part solid, or ground glass, and if they're calcified in a benign pattern, and then compare those nodules to the prior exam. So it's things that you're already doing. The nodules are measured on the lung windows, and they use an average diameter with the orthogonal measurements and an average of those two. And then, as Larry said, volumetric measurements may be helpful, particularly in the lumpy, bumpy nodules. And there are nodules where the maximal measurements can be the same, and yet the volume is increasing. So looking at your reformatted images is very useful, as he said, and looking at your volumetric analysis, if you have that available, that's also very useful. You might consider what the title of the exam is going to be in PACS, because you don't want people to read a study as a lung cancer screening when it's not, and you don't want a lung cancer screening study to be read as a regular CT without the lung rads part of it. And then you need to have the lung rads table available in the reading room, either posted at each workstation, or I have it on my iPad. The advantage there is you can really magnify it, so you don't have to get a telescope or binoculars to read the fine print. And then keep in mind, if you're not already doing lung cancer screening, the baseline for the actions depends on whether it's the initial screening exam or if it's a subsequent exam. I find it helpful to either annotate the images so that you have arrows on the nodules so the next person can find the nodules more easily and make sure that they aren't changing, and or I try and do both, give the image number or the table position in your report. And then another thing to keep in mind with the lung RADS 3 or 4 designation, where you're getting a 6-month or 3-month follow-up, if those nodules then stay stable and it says return to baseline screening, that's 1 year from the initial baseline. So it's not 1 year after that 6-month or 3-month follow-up, it's after that initial baseline screening. And then the growth is defined as greater than 1.5 millimeters in diameter. So you saw the lung RADS categorization. There is an S modifier for clinically significant findings, and then a C modifier if the patient has had a history of lung cancer. And again, we don't scan those people as screeners until they've been 5 months out, because typically they're being followed by their oncologist until that 5-year cure designation. These are examples of clinically significant findings, and some of these are, I know the registry is being changed because initially I think they didn't have emphysema as a field in the registry, and I brought that to their attention, so now that's there. So some of these will need to be put into the registry. I'm not sure at this point which ones are included and which ones aren't. And then for the radiologist, you need to find a way to ensure that the patient comes back, so that they come back for their annual screening, and if it's a lung RADS 3 or 4, that they're complying with that recommendation. We have a program, Robert Bauer, my partner who's here, has set up a program that we call Exam QA, and it's embedded in our PACS. And so when I'm reading these and it's one of those categories, I can click on that and say the patient needs to come back for a CT scan in 3 months or 6 months. And then we have a person who monitors those on a daily basis, and then they check the medical record to see that the patient did get the follow-up. We use this for other things besides lung cancer screening, but it's been very beneficial in preventing patients from falling through the cracks. So if you have a system like that, that is going to be very useful with your lung cancer screening program. I also notify the physician, particularly early on, because many times when you call them, it's the first patient that they've ever sent through for lung cancer screening. So if you can do a phone call or an EPIC, you can send a message through the in-basket, and that's tracked. And then there is a requirement that patients with actionable nodules be evaluated by a multidisciplinary team who will review the patient's history and the findings and then decide upon the appropriate action for that patient. And then for the coding and billing, I'm going to turn it back to Kari.
So with the CMS guidelines came the G codes. The G codes which opened up having our primary care physicians being able to pay for or get paid for their services, which I don't still think that they're believing most of the time when we're telling them that this G code is available, and it's you can actually charge for it with a visit charge as well. So plus they're receiving RVUs on it. Also the G code is out there for lung cancer screening, and the radiologist is receiving 1.02 RVUs for reading lung cancer screenings. Currently, CMS is covering, as everyone knows. Private carriers are also covering, but the one caveat is that if a policy for a patient is in place prior to the CMS recommendation or the CMS approval, until that policy is renewed, that lung cancer screening may not be paid. I did a quick report prior to this meeting on what we're getting paid at the university versus what we're not, and which companies are not paying us, or what have we done incorrectly so that we can get paid. A lot of it comes down to diagnosis codes. So what we're seeing is the ICD-10 codes. There was some confusion prior to the F17.2, I believe it's nicotine dependent code, was approved by CMS for coverage. So keep in mind that all pieces have to fit. It's a big puzzle. So if the documentation isn't done, if the billing isn't done, if the read isn't there and we don't follow up on our patients, they're watching us and they're making sure we're either getting paid for doing it right or we're not getting paid because we've misstepped somewhere. So just something to keep in mind. So this is, as Dr. Broderick spoke earlier, this is included in DICO, the registry. We're a part of Diagnostic Imaging Center of Excellence. We don't pay because we are a part of that for the registry, but otherwise it would be based on the number of radiologists. I have a CT tech who comes in about once a week who does all of the data entry into our database and into the registry. It was a quick and easy fix because she understands from the root cause, works with the nurses, and goes all the way through without a lot of explanation on what the CT scan is all about and what we need to do to enter this data in. Lung rads recommendations change based on accumulated patient data. As we're seeing and we're pulling data, and I believe I gave Dr. Broderick our latest data, we're seeing changes in how we're treating patients and how we're following them. So I see differences from when we started on how the physicians are reading them out and then later on. And it's just a small observation I made as I was looking at the data. So I can see it changing. I can see everybody talking about it. It's very interesting. So resources. For the medical physicists, CT protocols. A good paper is the 10 Pillars of Lung Cancer Screening. And we also have some quality safety resources, lung imaging resources. For referring physicians, for your knowledge, there's lots of should I screen? There's a lot of screening websites out there that these physicians can go to and get more information. ACR is one of them.